Welcome to this video conference coverage from the 2024 American Society of Clinical Oncology annual meeting in Chicago, Illinois, and the European Hematology Association Hybrid Congress in Madrid, Spain. In this series of 5 episodes, our expert hematologists, oncologists, Dr. Saira Ahmed and Anne LaCasce will review the most recent data for the treatment of patients with non-Hodgkin's lymphoma, including diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, chronic lymphocytic leukemia, and an overview of the hot topics in the field. Stay tuned until the end of the program, where Dr. John Winters from New England Cancer Specialists joins us for a discussion about how these data may impact community hematology oncology practice.
I'm Dr. Saira Ahmed from MD Anderson Cancer Center, and today I will be discussing the data presented at ASCO and EHA for the treatment of follicular lymphoma. 2024 has been an exciting year with 2 new approvals in follicular lymphoma. So zanubrutinib has been approved at an accelerated approval with obinutuzumab for relapsed refractory follicular lymphoma who have received more than 2 lines of prior therapy based on the phase 2 Rosewood study. So the Rosewood study is a phase 2 open-label multi-center trial of adult patients with relapsed refractory follicular lymphoma after 2 or more systemic treatments. Patients were randomized 2-to-1 to receive Zanu plus Obin versus Obin alone until disease progression or unacceptable toxicity. The overall response rate was 69% in the Zanu plus Obin arm and 46% in the Obin alone arm. With a median follow-up of 19 months, the median duration of response was not yet reached in the Zanu Obin arm and was 14 months for those patients receiving obinutuzumab monotherapy. The estimated duration of response at 18 months was 69% in the Zanu Obin arm. Across clinical trials of zanubrutinib, the most common adverse reactions include laboratory abnormalities and then hematologic toxicity with decreased neutrophil counts and thrombocytopenia. Patients did have upper respiratory tract infections, hemorrhage, and musculoskeletal pain between 30 to 40% of the time. Serious adverse reactions occurred in 35% of patients with follicular lymphoma who received the zanubrutinib-obin combination. On May 15, 2024, the FDA granted accelerated approval for liso-cel in adults with relapsed refractory follicular lymphoma who have received 2 or more prior lines of systemic therapy based on the Transcend Follicular Lymphoma trial. This was a phase 2 open-label multi-center single-arm trial for patients who have relapsed refractory follicular lymphoma. Eligibility required adequate bone marrow function to receive lymphodepletion chemotherapy with an ECOG performance status of 1 or better. The most common non-laboratory adverse reactions was, not surprisingly, cytokine release syndrome, along with headache, musculoskeletal pain, fatigue, constipation, and fever. So let's discuss the frontline therapy for the treatment of patients with follicular lymphoma. In the phase 1-2 EPCOR NHL trial with arms 6 and 7, epcoritamab, which is a bispecific CD20-directed T-cell engager in combination with rituximab and lenalidomide, demonstrated deep and durable responses, including a high complete response rate that compared favorably with the known results for rituximab plus lenalidomide alone. Again, this trial was adult patients with CD-positive follicular lymphoma, grades 1 through 3A, and they received rituximab and lenalidomide plus epcoritamab in arm 6. And the median follow-up at 21 months showed an overall response rate of 95%. This was the primary endpoint, and a complete response rate of 85%. Arm 7, if we remember, was the maintenance arm. So patients who had a standard of care treatment then received epcoritamab maintenance. And this demonstrated significant conversions from a partial response to a complete response. All of the patients who had a partial response converted to a complete response. At 21 months, an estimated 83% of responders remained in a response, and 90% of patients were alive. The most common side effects associated with maintenance were infections with COVID-19, and about 55% of patients did experience CRS. Let's now discuss the treatment of patients with relapsed and refractory follicular lymphoma. So one of the most exciting agents that we have seen in the past couple of meetings are the novel cell mod therapy. The combination of golcadomide plus rituximab in the treatment of patients with heavily pretreated relapsed refractory follicular lymphoma showed encouraging efficacy, including patients who were lenalidomide refractory or who had disease relapse post-CAR T-cell therapy. In the efficacy evaluable combination-treated patients, median follow-up was 6.6 months, which is short, but the best overall response rate was 83% with a complete response rate of 42%. And this did include 2 patients with prior CAR T-cell therapy. The median duration of treatment was 2.3 months, and the median duration of response was 5 months, with all but 1 patient remaining in response at data cutoff. This was a 2-part first-in-human dose escalation with then a combination arm that was the expansion arm. So there are 3 CD20-directed CD3 T-cell engagers in this relapsed refractory follicular space that we'll discuss. Mosunetuzumab, which has already gained approval, odronextamab, and epcoritamab, which have not yet gained approval for follicular lymphoma. In the phase 2 subgroup analysis, fixed-duration mosunetuzumab monotherapy showed durable remissions and clinically meaningful survival outcomes in high-risk patients with heavily pretreated follicular lymphoma, including patients that had early relapses within the first 24 months. IV mosunetuzumab was administered in 21-day cycles with step-up dosing, and there were subgroup evaluation for patients who were POD24, as well as patients who were older, above the age of 65, and patients who were receiving mosunetuzumab in 3rd line versus 4th line. In the phase 2 ELM study, odronextamab demonstrated deep and durable responses in a heavily pretreated patient population, with 91% of responders achieving a complete response. This did correlate to a favorable PFS and overall survival benefit at 24 months. Of note, the FDA has declined to approve odronextamab for relapsed refractory follicular lymphoma due to concerns about the progress of confirmatory trials. In the ELM2 study, odronextamab was administered IV every 21 days until progression or unacceptable toxicity, and steroid prophylaxis was utilized for the risk of CRS. Maintenance continued at every 2 weeks or every 4 weeks if patients had a complete response that was durable for at least 9 months. In the phase 1-2 EPCOR NHL1 study, epcoritamab monotherapy also demonstrated early deep responses in the largest relapsed refractory follicular lymphoma population treated with a T-cell engaging therapy to date. The complete response and MRD negativity was also assessed at cycle 3, day 1, and this was associated with an improved progression-free survival. The data suggests that mandatory hospitalization for CS monitoring is not necessary and further supports outpatient epcoritamab treatment for patients with relapsed and refractory follicular lymphoma with institutions that have the ability to do this treatment as an outpatient. We're now going to talk about CAR T-cell therapy in this space with relapsed follicular lymphoma. We'll talk about lisacaptogene maraleucel and tisagenlecleucel. So as mentioned earlier, liso-cel was recently FDA approved for the treatment of follicular lymphoma. In the phase 2 TRANSCEND trial, liso-cel showed equal clinical efficacy and safety with low rates of severe CRS, neurologic toxicity, and infections in both arms, both bridging and non-bridging therapy, which suggests that bridging therapy may mitigate worse outcomes and AEs associated with high tumor burden and high-risk features, although this has not been verified in an independent trial. So in the 3-year follow-up of the phase 2 ELARA study, patients with relapsed refractory follicular lymphoma treated with tisagenlecleucel maintain a high rate of durable responses more than 3 years after infusion, including patients with high-risk subgroups, those that have relapsed within 24 months of primary therapy. The best overall response of complete response rate by IRC was 68%, with an overall response rate of 86%. In the POD24 group, the 36-month PFS was 50% in comparison with 59% without POD24. And overall, the median PFS was 37 months. The correlative analysis suggests a higher baseline level of CD8 naive T cells are associated with improved long-term clinical outcomes. Again, these patients were relapsed refractory follicular lymphoma, grade 1 through 3A, and had been treated with at least 2 lines of prior systemic therapy. In this trial, bridging therapy was allowed. Now that we are all up to speed on the most recently presented follicular lymphoma treatment data, let's talk to Dr. John Winters, a community hematologist from New England Cancer Specialists.
Thanks so much, Dr. Ahmed. That was a great overview of really exciting data. And I do have a few questions. First, as we know, a number of patients who achieve CR after initial therapy may develop progressive disease. Which of the potential first-line therapeutic regimens that you discussed today are you most excited about for improving CR rate and hopefully progression-free survival in patients with follicular lymphoma?
So I'm really interested in the bispecifics. And I think that, again, we briefly touched on this in our large cell series, that while it's maybe a little bit of time before all community oncologists feel comfortable, I think that there are potentially really good outcomes with what we've seen with bispecifics plus kind of standard backbones of rituximab and lenalidomide. And potentially, again, there's some products that have less toxicity than others, particularly mosunetuzumab in comparison to the other T-cell engagers. So I think that is really something that is going to be a treatment paradigm shift in the future as we potentially move away from kind of chemotherapy regimens. I think there is potentially still the question to be asked, how long do you need to continue these treatments? A lot of patients really like bendamustine rituximab as a frontline therapy because it's a time-limited treatment with a fairly long efficacy for most patients. And so as we start to move forward and we look at these treatment schedules with these long tails, I'm not sure how exciting that's for patients.
Sure. Do you see bendamustine rituximab as problematic in first line for follicular lymphoma? I know given that sort of subsequent lines are likely going to be, T-cell engager therapy or CAR.
So I think that's really interesting for follicular lymphoma because we know in mantle cell lymphoma and particularly, in large cell lymphoma that there is a negative impact of bendamustine prior to immunoeffector cell therapy. I think the likely answer to that may be the time that elapses between the bendamustine and then immune reconstitution. So if you have a patient that has had exposure to bendamustine 2 years ago versus 2 months ago, it probably has a very different impact on their T cells. But we don't have that data yet. So that's still data that needs to be generated as we have longer term correlative studies done on kind of the, lymphocyte milieu going forward. So I think that becomes most problematic for the POD24 patients who potentially receive bendamustine rituximab. So we'll have to see going forward, if that really does negatively impact the next line of therapy. I think what I'm probably more worried about is what happens when you give a bispecific followed by a CAR. At least in large cell, in the data that was presented at ASH, it doesn't seem to have a significantly negative impact, but I think that's still a question that is not entirely answered in other types of lymphoma as well as with larger data sets.
Great, thank you. So liso-cel was just approved for treatment of patients with relapsed refractory follicular lymphoma who have previously received at least 2 lines of therapy. Does the lower incidence and severity of CRS and neurotoxicity enhance the feasibility of using liso-cel in a broader patient population compared with axi-cel or tiza-cel?
So I think we're just starting to figure out what are the variables that we can actually impact to mitigate toxicity. One of them is tumor volume. So the higher the tumor volume, the more likely you are to have CRS and ICANS. And then the other is clearly what is your co-stim. And Axicell, throughout all of the pivotal trials as well as real-world data, seems to have a higher rate of CRS and neurotoxicity, which potentially can be mitigated with steroid prophylaxis. So I do believe that the products that have less toxicity are probably much more amenable to penetrate the market in terms of going out to more community-like institutions and practices. At the same time, CRS and ICANS are still potentially fatal and have occurred in high grade in all of the products. So while it makes us a little bit less anxious, I think you still have to have the infrastructure to be able to care for the potential toxicity, because you absolutely don't want a patient who comes in with a fever to be treated with febrile neutropenia when in fact it is CRS, or come in with seizure-like activity and somebody not identify that it's ICANS. And so that continues to be a struggle, particularly in places where you don't necessarily have a big CAR T center. What about you? Do you feel like out in the community, people are much more likely to use Lisa-cel or Tisa-cel in comparison to Axicell?
I think that, if you have the infrastructure to do CAR T, you can probably manage the toxicity in the community. I mean, if you were a community center that's able to do that. We don't have, in our sort of region, everyone doing CAR T is an academic center that's, kind of large, and we're not really involved in making decisions on CAR T products. So it's hard for me to kind of answer that, I think, because I'm not doing it much. I think the trickier part for us is, should we do, who gets BiTE therapy in the community versus CAR T in, one of the major centers, and a lot of it has to do with patient willingness to travel, et cetera.
Yeah, I think the traveling, in your part of the world, the distances might be shorter, but the traffic is worse. Whereas...
Yeah, we get, I'm in Portland, Maine, and we have Mainers that are never going to travel to Boston. It doesn't matter, if life and death, not going. So it's been nice to have other options, though, and we've been trying to make those available. But we may eventually have CAR T in our community hospital, but it's, there's a lot of hurdles in launching a CAR T program, obviously.
Yeah, absolutely.
Our practice used to do auto stem cell transplants, way back, I think before FACT certification, et cetera. But
the regulatory hurdles are not insignificant either.
Right. There's, sort of regulatory, financial,
John, thank you for joining me today.
Thank you so much for having me. That was a great discussion.
Please remember to take the post-test and fill out the CME evaluation. And please watch the other ASCO EHA conference coverage videos where I discuss the latest data for the treatment of diffuse large B-cell lymphoma, and my colleague LaCasce reviews treatment of mantle cell lymphoma, chronic lymphocytic leukemia, and other hot topics related to non-Hodgkin lymphoma. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com.